healthcare should be accessible. But as you saw in Shachi Curl's presentation, too many patients are struggling to access the care they need when they need it. The lack of access to primary care is compounded by declining interest in family medicine as a career by Canadian medical graduates. After the first round of the 2023 CARMS match, there was a historic high of 268 unfilled family medicine positions, 268. The result is that providers are experiencing unprecedented exhaustion, burnout, and job dissatisfaction. Patients aren't getting the care they need. The current health workforce planning is siloed, focused on one profession in a single region. We need a planning framework that reflects the reality of complex, interdependent healthcare labor markets. We need to create environments where people want to work and where workloads are manageable. Now, in this session, we're going to talk about the role of team-based care in creating a more equitable and sustainable primary care system, including the potential gains and also the trade-offs. You're going to be hearing two perspectives today, one from a family physician who studies primary care, the other from a person with lived experience who believes that her brother might not have slipped through the cracks if he'd had access to an interprofessional team. And you'll have a chance to weigh in, both in person and for those of you who are with us online, through a moderated Q&A and through table discussions and virtual breakout sessions. Dr. Tara Kiran practices family medicine as part of St. Michael's Hospital's academic family health team. As a primary care researcher, she investigates how changes in the healthcare system affect patients, especially the most marginalized. In 2022, Tara launched Our Care, a national initiative to engage the public in co-creating stronger, more equitable primary care. And so I'd like to welcome Dr. Tara Kiran to the stage. Tara. Hi.
This is a CME accredited talk, so hopefully you'll see my disclosures up there. I don't know about you, but I've been part of healthcare reform discussions for a long time. And too often, we have at the table people like myself, family doctors, health professionals, administrators, researchers, clinical leaders, policymakers, but there's a voice that's missing. And often that voice is members of the public and patients. I believe that if we want to create a stronger system, we need to put the voice of patients and the public front and center. And that's really what Our Care has been all about. We launched Our Care back last year, and over 18 months, we hope to engage thousands of Canadians about what the future of primary care should look like, to co-create a vision. In fall of 2022, we started with a national survey. We heard actually from more than 9,000 people across Canada, people from all walks of life, and we've been very transparent about our data and what we got, and we've put it up on a website, data.ourcare.ca, an interactive tool that you can use actually even now to explore the results. Our second stage that we're in the middle of right now are deep dialogues. We call them provincial priorities panels. We're doing these in 5 provinces across Canada, in Ontario, BC, Quebec, Nova Scotia, and Manitoba. After each one, we're posting a report about the priorities that people in that province feel should actually drive the primary care reforms. But what I'm going to share for you today, too, is looking across those priority panels and what are some of the common themes that we're starting to see. Our last stage are community roundtables, because as we've talked about today already, the problems in our healthcare system don't affect everyone equally. We know that people who are more marginalized are less likely to have access, and we want to amplify those voices. So we're going to be working with community organizations to host one-day community roundtables to amplify those voices of people who are often left behind. This here is a photo of the Ontario Priorities Panel. 35 members who gathered together spent 40 hours deliberating about the future of primary care. You can see from the picture itself that they're a diverse group, and that's pretty deliberate. These are, I should also mention, these people were all strangers prior to getting together. So back in November 2022, when they met for the first time virtually, and then they met for 3 consecutive Saturdays virtually, they didn't know each other. And then they came together in person for the first time in February and met for 4 days in Toronto. We actually had over 1,250 people volunteer to be part of this process in Ontario. And among them, we randomly selected the 36, and it ended up being 35 that were able to continue with the commitment. And we randomly selected them so that they would roughly represent the demographics of the province. Because you see, we wanted to, in essence, bring Ontario in a room. And you can see kind of from that map that the people that we talked to that were in the room really came from all parts of the province. And as I mentioned, we've repeated this process now. This is a picture of our Quebec Priorities Panel that met in Montreal in May. Our BC Priorities Panel that met in Vancouver in June. And our Nova Scotia Priorities Panel that met in Halifax in July. And coming up in the fall, we'll have a Priorities Panel in Manitoba. So the Ontario panel report is up on our website, and these other 3 will be posted in September. What's the process like for them? Well, a really unique part of these dialogues is that a lot of it actually in the beginning is spent learning, because we know healthcare is complex. And for many patients and the members of the public, it's actually a black box. And they have so many questions. And so we try and actually put them in touch with some of the foremost experts. You'll see Dr. Kathleen Ross up there and many others that you'll probably recognize from this room. They volunteered their time to speak to this panel, to the various panels, and tell them and share their knowledge about what they knew. But I would say that actually some of the hardest work the panelists have to do is talking to each other. Because as I mentioned, they're strangers. They came with different perspective, different political perspective, life experiences, views, and they have to do the really hard job of listening to each other, respecting different people's perspectives, and then coming to consensus for what it is that matters most to them and how the healthcare system they would like to see in the future should kind of come to be. And so I want to share with you today some of what I've seen them say when we look across actually the 4 priority panels, because not only were they able to come to consensus in each province, but when you look across, we see a lot of common elements, starting with values. Each panel identified a set of values that they want to underlie the primary care system. And it's wonderful and heartening to see that actually many of these values are the ones that we opened the conference with. Right at the top, no surprise based on what we've already heard, accessibility. They strongly believe that everybody in Canada deserves access to primary care and that we should be removing barriers. And so equitable is really up there too, because they want that access to be for everyone regardless of their background. They really want a system that's wellness focused as opposed to sickness focused, that's holistic and preventable. They use the term accountability a lot. Accountability and transparency, although it was probably unclear in many times who was actually accountable for what. They want it to be patient-centered and patient-empowering. They learned a lot during the process, and they wanted other citizens to know what they learned. Public and universal and sustainable. They also, when they put together each panel a series of recommendations, and when we look across again, we can identify some common themes. Some of these include things like legislating EMR interoperability. Wouldn't that be nice that our EMR systems talk to each other? And that patients might even have one patient record that they could have access to, that they could delegate access to a caregiver or loved one and to their health professional team. They really wanted investment actually in upstream. So I think we had a bit of a debate whether people thought money was the answer. Well, I think here they said, well, okay, if you look at the total health budget, actually a higher proportion should be spent on primary care and preventive care. Along with that, actually, there's a bit of a discussion today about public and private, and I will just say that, sorry, I'll go back here, but I'll just say that they were pretty clear overall that they wanted to see coverage for prescription drugs, dental care, mental health care, and eye care expanded. So they wanted to see expansion of coverage more so than they wanted to see restrictions or more privatization. But probably the one thing that they agreed on most was that we needed to scale up team-based care. And so this here is a direct quote, actually, from the Ontario panel report. In order to reduce provider burnout and provide more access to comprehensive care, the Ontario public wants the primary care system to move away from solo providers towards models of team-based care. And the panelists went a little bit further to talk about what it is that they really wanted to see in these team-based care models. So they were particularly enamored, particularly in BC and Ontario, I think, with the community health center models. They liked the fact that they were interprofessional, that they were community governed, and that actually many of the physicians there were employed and on salary, which they heard from folks, the speakers, that is something that new grads in particular were looking for. They thought the rollout really should prioritize equity. And I'm not sure why my slides are auto-advancing, but anyway, here we go. So they really wanted to prioritize equity and make sure that as we roll out teams, that equity is kind of at the forefront. If I can go back, and maybe somebody at the booth can help me go back one here. But I would say that in Nova Scotia, they had a couple of really interesting recommendations. One was they wanted healthcare professionals to be incentivized to enter teams. And so they, for example, mentioned that government perhaps could subsidize overhead or space or have some cost sharing of administration as incentives to get people to work in teams. And they actually also wanted to incentivize specialists to join the primary care teams so that all the care patients received were in one place. Now, if I could advance to the next slide. I would say that one of the boldest recommendations that they had was to ensure that every Ontarian had access to a primary care home. And that they drew an analogy between the primary care system and the public education model. So that government should move towards automatic rostering, similar to the public system. While health teams should be mandated to accept any patient from their catchment area, it's important to maintain an element of patient choice. And they went on to kind of describe how that could happen, that patients should be able to pick from providers within a team. If they move neighborhoods, they'd still have the option of staying with their old one. But fundamentally, what they really wanted was to move away from this awful situation that people are in right now, where they're having to fight to get on a waiting list, to get to see a family doctor, any doctor, to even fight to get into a walk-in clinic in many of the provinces that we were in. And so what does this mean, if we have a geographic catchment? They went further to say, okay, well, independent walk-in clinics should maybe be amalgamated here. Virtual care should be used to prioritize equity and access for rural and remote and underserved communities. And primary care teams should be community governed so that they have the interests of the community at heart. How does our current reality then match what it is that people said that they wanted? Well, I'm going to show you a few slides from our survey results from back in the fall. So we asked people who did have a family doctor or nurse practitioner, who else works with them in the same practice? And what you can see here on the slide is that about 70% said, okay, there were other family doctors working in the same practice as theirs. But very few reported having other members of the health professional team within that practice. Maybe about 35% said they had a nurse, 30-ish% said they had a nurse practitioner, but less than 15% said that they had a pharmacist or dietitian, and less than 10% said that they had a social worker. And what was striking, and I think this is true actually for many of the results in our care survey, was that there was immense variation by province. So provincial policies matter. That's one lesson we'll take away from our care. You can see in Quebec, as an example, if we look at the percent reporting social workers in their practice, Quebec and Ontario, much higher percent compared, for example, to British Columbia or the Atlantic region. Now, I would say when we're talking about interprofessional primary care teams, I think the foundation, though, often has to be doctors working effectively together in groups, cross-covering for each other, sharing a patient records. And we did ask people also whether that was the case. So if their family doctor or NP was away, could they get care from another family doctor or NP from the same practice? And unfortunately, only 50% said that they could, which to me kind of illustrates that we have a long way to go towards even physicians working together effectively in a group in primary care. But of course, the most striking and worrisome finding from our care survey is that far too many people don't have access to care. 22% of people said they didn't have a family doctor or NP they could see regularly for care. That was across Canada, but in some regions like Quebec or the Atlantic region, it was as high as 31%. So translate 22% to the whole Canadian population, and that's 6.5 million people who don't have access to the front door of the healthcare system. A really depressing stat. And what's even more depressing, I will say, is that when we look at population demographics and we look at we look also at the healthcare human resource trends, we can see that that problem is probably only going to get worse in that short term. And even if we graduate more medical students with more medical student spots, more medical student and residency spots, train more nurse practitioners, we're probably still not going to meet the need unless we really radically change the way that we work. And what that means is we need to allow physicians and nurse practitioners, people who act as the most responsible clinician, we need to be able to grow their capacity to see more patients. That's the only way I think that we're going to get to a vision where everybody has access to primary care. And of course, one of the answers to doing that is teams. It's not surprising that there's a strong evidence base for teams and that professional organizations have been calling for teams. We see it in the Patient Medical Home, in one of my favorite articles about the 10 building blocks of high-performing primary care, or this recent report from the US on primary care. What do I mean by interprofessional teams? 2 or more clinicians from different health professions consistently working together to care for a common group of patients, to deliver primary care, the 4 C's, what I call first contact, coordinated, comprehensive, and continuous care. As I said, ideally they share a record, and ideally they work under the same roof and cross-cover for each other. I will also say that there can be other types of teams and team workers who are not professionals, so community health workers, medical office assistants, clerical staff, they all have great roles to play, but a lot of the evidence that we see right now that I'm talking about really relates to interprofessional primary care teams, so other health professionals. So we have actually some good experience in Canada about health interprofessional teams that we can learn from. I know the most about Ontario, where we've had teams now for about 20 years. And what we see from some of the research that we've done in Ontario is that patients who are belonging to a team practice, they're more likely to get recommended tests for chronic conditions like diabetes. They're also less likely to visit the emergency department. I should put the caveat that in Ontario, doctors who work in teams, they're paid by capitation as opposed to fee-for-service. And so in all these studies, we're comparing doctors who work in capitation with a team and doctors who work in capitation without a team. How doctors should get paid in teams? A whole other question, and look forward to your thoughts on that. I myself have been lucky to work in a team-based practice for a long time, first in a community health center and then for the last 12 years at St. Mike's. And I know many of the innovations and improvements we've done in our own practice have really only been possible because myself and my colleagues, we work in a capitation model and we work in a team. And so together we've been able to do things like measure a whole bunch of indicators, including patient experience, and actually see movement in indicators like after hours care, and improve cancer screening rates, reduce disparities in care, and even improve opioid and benzodiazepine prescribing. Now, I had wanted to adjust my slides, but it was too hard to do that because what I would have shown you next was actually an awesome picture of our team yesterday celebrating Blue Jays night. Because I will say that one of the things for me about team-based care is it gives me a lot more joy in work. We heard Kathleen Ross talk about how tough family medicine is. Patients are more complex, they have more social needs, we've got more evidence to keep up with, we've got more different parts of the healthcare system we need to coordinate with. And I rely every day on my team to help me to do a better job and feel supported, to be honest. And so it's not surprising, I think, when we think about teams to say, well, okay, we've done right, interprofessional primary care teams can increase capacity, improve clinician work life, and improve quality of care. So all of those three things. But fundamentally, I think we really need to focus on that part of increased capacity for the reasons I talked about earlier. But you'll notice that I said done right. And what does that mean? Because I think the details matter, and that's what I'm really hoping to get your feedback and your thoughts on today when we're having a discussion. Because actually, we don't have good evidence on some of this stuff. So, like, which health professionals should make up the team, you know, and what ratios doing what roles will actually get us better capacity? What's the primary goal of teams? Is it to increase capacity? Can we agree on that? Or is it to increase capacity to serve the most vulnerable or marginalized? What training and oversight is needed? When teams were implemented in Ontario, there was no standard training. Each team had to do it themselves to figure out, you know, how to train up their nurse or social worker or pharmacist to optimize that role within the team. How about governance and accountability? Again, in Ontario, different governance for physicians and different governance for the other team members, leading to some unfortunately dysfunctional situations. And of course, as we talked about, how are physicians and others paid? I'd like to highlight 3 lessons from Ontario that we should be thinking about as we think about scaling up teams. The first is one that we just already talked about, that we do need to set it up so that physicians work effectively in groups, and that actually didn't occur in Ontario. Physicians could be part of a team and actually not work under the same roof or have shared records or cross-cover for each other. The second is that we really need to be clear on the objectives, because I think we kind of missed the boat in Ontario on one critical aspect, which is increasing capacity. There was accountability for improving quality of care. There was a lot of measurement, or what I would say is bean counting almost, like, you know, what are people doing with their time? But actually, we lost the focus on increasing capacity, and teams in Ontario don't necessarily see more patients than physicians not working in a team. Why is that? Because often team members are doing duplicative care as opposed to, or additive care as opposed to substitutive care. So someone's seeing a nurse for their diabetes visit, but then still seeing the doctor, as opposed to the nurse being able to manage stable chronic conditions together maybe with the pharmacist and some medical directives. The third lesson, and probably the most important, is that we need to design for equity. My colleague Rick Glazer has done some work in Ontario and found, you know, we've got 25% of the population covered in teams, but it's completely irrational. The areas with the highest need actually have the lowest access. So when we're rolling things out, let's get that right. I want to end on a reflection on trade-offs, because I think that's where the discussion really needs to go. I'm often conscious, and here in this room I'm conscious, that as physicians actually we hold a lot of privilege, a lot of power, and a lot of autonomy. But then there's some things we don't have. You know, if we're a family doctor, we don't have this sort of a team often. We're running our own small business. We have to find someone to cover for us when we go on vacation. We're running, you know, it's part of running your own small business. Well, what if we did trade some of our autonomy in return for some more supports or benefits? Would that be better for us? Would it be better for the system, better for the patients? I think the other trade-off we need to think about, okay, so if we move to a system where we all work, you know, in these geographic catchments, really big shift. Are we going to stretch our resources too thin? Lots of fears, uncertainties around that. But, you know, let's say it's hard to serve everybody, and let's say, you know, the quality of care goes down overall, and maybe timely access is difficult. But how does that compare to where we are right now, where we have a system that have haves and have-nots? Some people who have access to primary care, some people who have access to Cadillac primary care with a huge team, and some people who have nothing. So let's weigh these trade-offs and think about the change that's required, and, you know, what loss and fear we may have as we think about the change. And as we think about where it is that we need to go, I really want to ask us to think about patients in the public and their preferences and priorities as our North Star. So take a look, ourcare.ca. You can peruse the reports and the data yourself, and I look forward to your discussion.
Thanks so much, Tara, for a very clearly outlined presentation. We're looking forward to speaking about it more. A reminder to our audience that we'll be taking your questions shortly. Online participants can post their questions on the virtual event site. People in the room can also post and upvote questions on the app that I mentioned a little earlier, or raise their hand, and one of our staff will bring you a microphone. I'd now like to introduce our next guest. Teri Price is Executive Director of Greg's Wings Projects. She became a passionate advocate for improvements in the health system after her brother Greg died unexpectedly in 2012. A provincial review of his case found that missed faxes and follow-ups and poor sharing of health data ultimately cost him his life. Teri, welcome, and thanks so much for sharing your perspective. Teri Price.
Well, thank you. I'm extremely excited for this discussion. Teamwork and team-based care is something that we've been talking about for 11 years now. And I think some of the momentum and the work that's being done, we're really excited to see some of this sort of the current state and the potential for the future. I think for me, teamwork and team-based care resonates really strongly, partially because of who Greg was. He was a really good teammate. At his funeral, there was a number of stories of people that shared how valuable he was as a member of their teams, both from the players and from his coaches and any of the extended teams that he was able to interact with in his life. He was coaching himself at the time of his death. And I think when we got to learn from Ward Flemons, when we were going through the whole process of the investigation after Greg died, and Ward started to share more about teamwork in healthcare and how critically important teamwork is in healthcare, I think we really latched on to those ideas, and we've continued to sort of frame a lot of our discussions that we have around that early learning about teamwork and the critical importance, and in some cases the lack of teamwork in healthcare. I'm just realizing now that I didn't do the disclosure. There we go. So just want to acknowledge as everybody else has with the disclosure for the accreditation. So this, I think there's a few things that we we have the short film called Falling Through the Cracks. We've had the film for about 6 years. We've done more than 550 screenings of the film at this point, and we're creeping up to close to 50,000 audience members. And the combination of Dad and I, whose dad is also in the room today, or one of us, have joined almost all of those discussions. So a lot of what we bring when we're sharing our ideas comes from all of those discussions that we have had. And a lot of what we continue to sort of evolve and emphasize is linked into some of the document and that's on the screen right now. This document is also available. The link is at the bottom. It is tiny. Oh no, that's the team scheme link. So this link, gregswings.ca/teamwork, will bring up a slightly expanded version of this document. It's based on the teamwork framework that is taught at the University of Calgary that we got introduced to by Ward. And that framework is based on a team steps and the CNIH interprofessional, I'm not exactly sure what the right national interprofessional competencies maybe. framework is. But the point is that this is a framework around the importance of teamwork that we tend to use to emphasize what we see as being critically important for teamwork. Because sort of, I think, as Tara had referenced quickly, that just putting people together doesn't necessarily mean that we're going to get the teamwork outcomes and the benefit from teamwork that we actually want to see. There's a great YouTube or a great keynote speech that's on YouTube that we quite often use that sheds light on the difference between group work and teamwork, and how we have to recognize that we actually rely on each other in order to be successful as a team. And so I'll go through really quickly these 4 components. It's not that we believe that this is the only way to frame teamwork, but it is something that when we're talking about teamwork and referencing the term over and over, this is a little bit of a deeper dive into what we mean. So being able to collaborate and being able to make the collaborative decision-making, shared decision-making, that true partnership with patients and the members of the team. Being able to support each other and make a plan, and having the culture within the team that everybody's comfortable and recognizes how critically important it is to speak up. Because I think that's one of the things why we latched on to teamwork very early on, is because we believe that safe care happens with teams, that we're not actually going to be able to move the needle on patient safety and safety in healthcare in general without actually recognizing how we rely on each other and how critically important that is. And so being able to have that supportive culture where everybody, including patients and families, are comfortable to speak up is what we want to see as a foundation for the future of our healthcare system. Underneath the communication component, the sharing of information, so that the points around being able to share information between EMRs, really on a team, how do you function on a team if you don't have access to the information you need or ways to be able to communicate? And again, that includes patients and families being able to access the information and be able to communicate with their team. Situation monitoring is about everybody being on the same page and understanding the plan, what to do if something goes sideways, and also being able to think intentionally about anticipating the challenges that may come. It's incredibly valuable for patients and families to sort of be able to have that level of understanding. And it's one thing that I don't think healthcare necessarily does really well, is the anticipating what may happen versus just reacting. And leadership and membership is really about who is on the team, and really making sure that we recognize that you do rely on each other, and that patients and families are included as members of the team. I think quite often when we talk about this, we sort of move to and really the conversation around team-based care in general is sort of the micro level. At the micro level, how do we enable individuals to work together? I mean, we try and emphasize thinking of teams from the perspective of patients and who is on the patient's team. But I think there's also a discussion that can be had at the macro level of the system, and how do we enable some of these things? Are we actually collaborating effectively? Are we sharing information effectively? And really recognizing for the future of our healthcare system that we need to be able to work as a team to break down those silos and implement some of the same components when we're working between provinces and federally, or between primary care and other parts of the system, because we are facing a lot of challenges right now, and really don't believe that we're going to be able to sort of work our way out of it without collaboration and teamwork as being part of the plan. We need to think through what are those conditions that we need in order that will create the possibility of making teamwork the default, the easy way to go, instead of, so what shifts in mindset do we need? What kind of system change do we need? How do we actually incentivize teamwork and support teamwork, instead of it being something like right now, it's actually extremely challenging to be able to have the kind of experience that's explained as part of this teamwork framework. So I think really just emphasizing that everybody has a role to play, both in enabling effective teamwork at the patient team level, and all the way through the spectrum up to the role that we have to play in speaking up and advocating for and collaborating with all of the other organizations and individuals that are doing great things. We are optimistic because of a lot of the conversations that we've had. I'm not sure, I know the theme for the conference has bold ideas as being part of the theme, and I'm not sure I would confidently say that teamwork is a bold idea. But I think in order to actually get to a place where the experience across the board is better, is something where we do feel that we're supported and that we are a member of a high-performing, effective, competent team. We do need to be thinking about things a little bit differently, but that it is possible. And yeah, I think I'll stop there. Hopefully we'll get some good questions and discussion. But yeah, just sort of want to end on that optimistic note. I think there is momentum right now, and we're really excited to be a part of it. That's one of the benefits of sharing the film and then connecting with people, is that there's a lot of people that are recognizing, regardless of what professional role or sort of where they sit in the healthcare system. There's a lot of people that want to be on this team that's working towards a better healthcare system for the future. And we're grateful to be a part of that, and really optimistic and looking forward to the future, and in particular the next discussion.
Thanks so much, Teri, for sharing your story. Your lived experience is really, really valuable, so we do appreciate it. We have two questions right now from the virtual Q&A. But just before we get to that, I just want to clarify something, Tara, because there might be some folks who are not medical practitioners who might be a bit confused right now, because they're going to say, we always thought that physicians were part of teams, or nurses were part of teams. So when you say team-based care, can you just clarify that for us? What does that mean exactly? Because haven't you always worked on teams?
It's a good question. So I think first of all, we're talking, largely my presentation was focused about teams in the context of primary care, so seeing, let's say, your family doctor. And as we can imagine, I mean, many of us have experience going to see your own family doctor, and when we have, let's say, if we think about 20 years ago and maybe also your current experience, when you go to see the family doctor, what kind of office are they working in? Is it them by themselves with a receptionist? Is it them with other doctors and a receptionist? Is it them with a nurse and other doctors and a receptionist? Or is it them also with a pharmacist and a social worker and a nurse practitioner and a dietitian? And so I'd say that, 20 years ago, it was really common that when you went, it was maybe one or more physicians working together with a receptionist. And as I said, is that a team? I don't know. I mean, there was a receptionist who wasn't necessarily, they had a really important role, but the physicians didn't necessarily cross cover for each other. So are they a team? We can have a discussion about that. But what we're talking mostly about here are interprofessional primary care teams. And I'd say 20 years ago, that was uncommon, not non-existent, because there were community health centers and other models, but uncommon. And I think that would match people's experience. And what we're talking about is shifting, so that the common experience should be that when you go into a primary care office, you're not actually seeing the family doctor. You're talking to a receptionist, and if you are presenting, let's say, with a mental health concern, maybe you see the social worker first. Or maybe if you have a stable chronic condition and you have a question about your medications, you're directed right away to the pharmacist. So you have other people who are taking responsibility for aspects of the care. It's not all falling on the family doctor to navigate and do themselves.
Okay, thank you. We have a question from Humera Sarwar. And so, Humera, are you there? I think Humera has a question.
Can you hear me?
Yes, we can hear you, Humera. You can go ahead.
Thank you so very much for having me. And thank you so very much, Dr. Tara and Teri, to share their experience and the proposals. I have, you mentioned about the micro level team collaboration, and I definitely rooting for that because people do need more vast team, and that will reduce the burden on the family physician. But I would like to comment on one thing. At the beginning of the session, it was mentioned there was 286 unfilled seats for the family physician allocated for the Canadian graduates. And simultaneously, you also mentioned there are 22% of Canadian population who does not have access to family physician. So I do believe there should be a collaboration at the macro level, that policymakers to understand how to resolve these problems. Because on one side, there are people who cannot have access, and there are people who can provide the service, but due to one reason or other reasons, if it is not filled by the Canadian doctors, maybe they can take on board the international physicians who come through the process. So that is one thing. And another thing is, it was mentioned, diversify in the team approach, and definitely it's a good idea. But because the family physician's roles become so burdenized, lots of pressure, more people and less people who can access them, and less people to solve the problem, how the holistic approach or the preventive nature of healthcare support, that is the kind of a Canadian health policy is, be offered to the people when doctors are so constrained with time limits? That's the question. Thank you.
Yeah, maybe I could start with that. I mean, those are two great points and questions. Absolutely, we need to make family medicine a more attractive profession. And some of that involves pay that's more on par with other specialists, because we as family doctors are specialists, and we need pay that matches the complexity of the work that we do. And it's not just the amount of pay, but the type of pay. So, you know, what we see from colleagues like Ruth Laverne's work is that new grads actually, they increasingly want options to be paid as employees, or to be paid not through fee-for-service, but capitation or other kinds of means. And then the new grads and many current folks, you know, they want to work in a place where they don't have to be responsible for the business of primary care, but can focus on the doctoring. And so that's, again, you know, if we think about the public school model, can we have teams that, you know, are run by professional management and clinician-led, maybe, you know, like there are many different ways to do it. It can be physician-led, but you're not all physicians themselves, in order to be a family doctor, have to set up their own small business, because some people just don't want to do that. So we have to provide options out there for people who just want to be family doctors and just focus in on the medicine. Absolutely, international medical graduates are one part of the solution. You know, we don't want to poach from low and middle income countries. I will say, though, there may be some high income countries where doctors want to leave their system because things are bad, not just in Canada, but I would say they're worse in places like, maybe, let's say, like the UK right now. And what we saw in the match actually was the number of unfilled spots really dropped dramatically after they were opened up to international medical grads. And I'd say all of our panels were pretty much unanimous with opening up training spots for foreign trained individuals. Your second point now, I'm blanking on it, but I know it was a good one, because I was going to respond to it as well.
She also said,
it was about, can you just...
Thinking about the macro level of the system and the collaboration that's required in order to... Yeah.
In order to...
I think it's probably related to creating those conditions that we can have the strong primary care and the transformation in the system that's required in order to release some of the burden and the expectations on primary care. I think talking about the load that is on your shoulders right now. Mm-hmm. And I think, well, unless I'm misinterpreting the questions, the first part and the second part are very related. If we don't actually think about how we can transform the system so that that you're working in conditions that you're satisfied and happy and excited to do the work that you probably signed up for medicine to do, then it's going to be hard to continue to recruit into primary care. Hopefully that's what the question was.
Sorry that I forgot the second question. I had a response ready.
I have a question here from Shazma Matani, who says one of the biggest barriers to some team-based care, often in the context of NPs, is a dialogue that allied healthcare providers are a replacement for family doctors rather than part of a complementary team. What do you feel is the best way to address this and move forward in an effective way?
Yeah, that's such a great question, and I think it also speaks to this feelings of, I think, fear and loss, because anytime you have change is loss to some people, or to many people. And we have to kind of put on the table, what is it that we're afraid of? What might we be losing in the transition? And some of it might be that we're losing some of our power and privilege and autonomy, you know, but as I said, I think there are other ways that we can get back. And I think what benefits, and I think, you know, we have to stop being afraid that we're going to be replaced, because basically I don't think we can be. I mean, the public, they talk about family doctors more than they talk about nurse practitioners. We're delivering 95% of the care, and the reality is that we can train many more family doctors and fill all those residency spots and train nurse practitioners, and we still won't have enough people to deliver the primary care that we need. So there's no need to have turf wars, because there's so much turf. We can't cover it all. And the only way we can cover it, actually, is by working together as teams and really empowering others to take on roles. Oh yeah, now I remember her second question was around preventive care. And so I think the other piece is that, so the patient is part of that team too. And so the other piece that our public members talked a lot about was patient empowerment. They want to know how to navigate the system themselves. They want to know how to self-manage their conditions. And right now, we do a terrible job at those things. I mean, even during COVID, we did a terrible job telling people what it is that they needed to do. Maybe in the beginning a little bit, but then as things got more nuanced, like, it was hard for people to find the right information. So we need to make that more of a systems approach. It's not every individual family doctor who should be educating, you know, their community of patients. We should be having some common education, whether that be in classrooms all the way to high school, to university, public ads. So many layers there.
There are lots of questions here,
Okay.
but there's a question from Diana.
Oh, there's
There's
lots, I think, in
questions
front
on
too, yeah,
Okay.
sorry.
Okay, I'm going to take this one question here, and then I'm going to come to you. But Diana Welt's asking, it's a very practical question. How do you propose to help primary care doctors set up a team care practice?
Oh yeah, good question. So, I mean, I think we need to get funding for it. You know, I think what's tricky right now is that many doctors are paid fee for service, and the only way to get it to have a team would be to try and pay for it out of your earnings, and then have that person increase your efficiency to the point that maybe you'd be able to make that back. But I don't think that that's realistic most of the time. And so we do need government to invest. Governments need to increase the proportion of money in the whole health budget that's towards primary care, and I'll say in Canada that's about 5%, and OECD average around 22 countries is about 8.3% or something like that. So we're not at the OECD average when it comes to the percentage of the total health budget that's on primary care. We need to invest in primary care, and that includes money for team members.
Okay. We're rapidly running out of time for this segment, but I do want to take two questions from the audience, and then we'll go to the table talks. So I just can't see. Is there a question out there?
She's just
There is?
walking the mic
Okay,
over.
super.
Is this working?
It is.
Yeah.
I just signed up. So I've been listening to this, and one of the questions I felt we should ask is this: can we realistically scale up capacity to address this avalanche of need? Or is it time we should focus our attention in reducing the stem of need? Because the assumption is that the chronic diseases are fait accompli, they are inevitable. But we know also there's increasing evidence that if we address the social determinants of health, people will not even need us so much. So why don't we now focus on that more? Because we cannot train enough people.
So it's a question about prevention, really.
Absolutely,
Yeah.
and I think you saw the values there that were laid out by the public members. They wanted a system that was wellness-focused, not sickness-focused. They recognized exactly what you're saying. They recognized the issue with social determinants of health. And actually, that's why they also recommended expanding Medicare. So it's not just doctors and hospitals that are covered, but it's mental health care and eye care and prescription drugs and dental care. Because how can you be well unless you can have all those needs met? And absolutely, if those needs are met, then like it doesn't fall on the doctor. I can't do a lot for people who are having problems with their teeth. they need to see a dentist. And unfortunately, in the way that our society is structured, that's not easy. So there's issues around coverage, there's issues around, as we talked about, self-management and health promotion. So yeah, we need a whole shift in the way that we work.
Another question out here? Yes? Yep. Was there another question? Yep, I have one more. Oh, right over there, sorry. Yep.
Michelle speaking again. There are 32 long-term boil water advisories in 28 communities in Canada. We're actually up to 37 now, which has gone down from, I believe, 48 or something. But when you look at those statistics, doctors don't even have an opportunity to work in a sanitary environment. And the communities that don't have these basic water life abilities to be able to maintain their health, there's a problem there. You've got a whole bunch of bureaucrats. Why are the bureaucrats not trying to work with the government in getting this water situation fixed? Because I think that would be a very good use of bureaucracy, and for the doctors to be able to doctor in a decent environment. We have very few First Nations doctors. Of course, we're getting more as we go, as years progress. But our doctors are being transferred. Not so much transferred, but they have to be on call. Like right now, we've got one First Nations doctor who may be going to the Northwest Territories because of evacuations out there. We have another doctor that started out here in general practice and ended up going into research. So we need to understand that there's so many fields for doctors and physicians and all our helpers that we can't just be sitting here with just teams of doctors and nurses. We have to increase the team, and we have to use more people to be able to get that level up to par just for the basic people. So the privatization doesn't make sense at this point in time until we get actual equality somewhere along the way. That's all I have to say.
Tara, I don't think the speaker's disagreeing with you.
No, I think it's everyone deserves access to clean water, 100%. We need patients, public, and of course it's part of having a good working condition. And yeah, the health workforce has to reflect the population of patients we serve, and we have a long way to go when it comes to providing safe, culturally appropriate care. And in fact, some of the recommendations that I didn't talk about, are around expanding Indigenous models of care, for example.
We have another question from the virtual space. Ambreen Fatima. Ambreen, are you there?
I'm there. Good morning, everyone. So thank you so much for the great presentations and the numbers that was brought up. I do have one question. First of all, I apologize, my video is not working. So my first question is, because of this shortage of the family doctors and how most of the Canadian physicians are not putting their stuff for family practice, and we really need it. Now my question goes back to the numbers of healthcare providers, the family physician, nurses who are already in the country. They're not actually looking forward to be brought into the healthcare system. There are many other backstage, or there are many other problems that they're not actually a part of the Canadian system, whether it's going to be as a physician, or even if they have been trained as a physician and they're working. The other thing is, sometimes they even go to the universities to get education as a physician assistant. Even the spots are so less. The candidates for the applications, for example, for any university is 300 versus there are only 30 seats. We needed to actually leverage a lot of these skills and education that is already in the country. And then we're trying to understand, okay, one of the possible solutions that I can think about is, okay, we do have, they're already skilled, the 5 things that the Canadian system might not even have to go, they can actually shadow family physicians in order to understand the Canadian system. and by another steps. There might be a pilot projects to work on so that everybody can work, regardless. There are so many HCP that are working into capacity, like cab drivers, pizza delivery, and honestly, as a community, when we meet,
Sorry,
there's a
Adrian.
lot that's being put.
Sorry, Adrian, we're just having, I'm having some trouble
I
deciphering
can't.
what you're saying. I was wondering if either of you were,
I
is it
think-
clear to any of you?
I think that one of the early points I think Adrian was making is that we do have to make it easier for international medical graduates who are here living in Canada to work in a way that allows us, for them to have a satisfying career and for us to be able to utilize their skills in a way that we know we need more workforce. So absolutely, that's again, like I said, there was pretty much universal agreement among our public members that we need to do that. In particular, we've actually done a couple of the roundtables. We had one with our Afro-Caribbean Black community in Durham, Ontario recently, and that was a resounding theme actually, because it is also one way to increase the proportion of racialized healthcare professionals that are there, and it's really important that members of racialized communities, Indigenous communities, have people who reflect them among the workforce.
We want to get to the tabletop discussions, but very, very briefly, Teri, I'd like to hear from you about how patients can become more engaged in this process. What role do you think patients could be playing in bringing about this fundamental cultural change that you think needs to happen in medicine?
I think that there's lots of patients that are, and there's a number of people in the room that are patient partners and are both, I'm assuming, in their own care, are partnering with their healthcare team and have that sort of approach to their care, and are very engaged. And they're also making an impact across the system. I think we need to be willing and potentially a little bit vulnerable sometimes about the conversations we have about our healthcare system, and being more transparent about the current reality, but also have that focus, sort of that North Star that Kathleen mentioned in the discussion this morning around where do we actually want to go and how do we get there, and that you have to have patients and members of the public as part of that discussion, and being able to meaningfully contribute and be on that team that is going to be able to define what the future of our healthcare system is. And I think we were in that position before Greg died. There's nobody in my immediate family, well, I have a sister-in-law now that's a nurse, but nobody in our immediate family decided to go into healthcare. And so there was a lot of things that we were very shocked to learn about in the investigation after. We made tons of assumptions about the flow of information, the incentivization for people to work together, even the incentives in the healthcare system. We didn't really realize how impactful fee-for-service is. And so I think just having those open discussions, and we even saw it again this morning a little bit in the private-public discussion. There's so many incredibly important discussions that we have to have with patients, with the care teams, but with the public, and being transparent and honest about the current reality, why our experiences are the way that they are, but also be looking to the future and sort of forming that vision of what the best healthcare system we can have could look like, and enabling everybody to contribute to that, and knowing that we need everybody to contribute to that.
And this is a topic that many people clearly want to contribute
for sure.
We have so many questions, obviously here, but also in the chat, and we'd like to get to them. But really right now, we're going to shift a little bit and move to the table talk discussion. Because for the next 30 minutes, we're going to be breaking into smaller group discussions about 3 questions related to team-based care. We're asking that our virtual attendees return to the Zoom link to begin their virtual breakout sessions. For those of you in the room, you're going to find a template for taking notes at each table. Now, in most cases, we have a CMA staff who will take on the role of note taker. For those tables, though, without a staff person, we're going to ask that someone volunteer to take notes. And we're also asking that each table select someone to moderate the discussion. We have 4 family physicians who will be monitoring the discussions and reporting back to the entire group at the end. They are Dr. Allison Kennedy, Dr. Jean-Joseph Gondé, Dr. Kathleen Ross, and Dr. Rita McCracken. So please start with the first question on the template at your table. And for those who wish to have the discussion in French, en français, Dr. Condé will be moderating a table near the back of the room. And you will have about half an hour for this discussion. Okay? Thanks. So welcome back. It's time to hear about the table discussions that you've been having for the last 20 minutes. Our 4 family physicians are standing by throughout the room with their summaries. So I think we're going to begin on the left-hand side, your right, with Dr. Kennedy. Dr. Kennedy, you can summarize what happened at your table discussion. Is Dr. Kennedy there? He is, okay.
Thanks. Okay, so we were given the task of answering who should be on the primary care team from the perspective first of the clinician. A lot of talk about this. Certainly nurse practitioner was mentioned first. Interestingly, the administrative people in your practice or team are very important, and they can act as a navigator themselves. Social worker, really high on our list. Again, very important function to improve the navigation of patients through the healthcare system, and particularly integration back into their home communities, especially if they've ended up in a tertiary care service. And also the navigator can help transition to self-care at home. Somebody had mentioned that earlier, and that's an important aspect. That also came into the patient perspective. The communication is important to have different avenues of communicating with your medical home, texting, phones, hopefully someone answers. If that doesn't work, some other way to communicate and get a connection to the team. And very important from the patient perspective, which we tried to reflect, was how the team works together, communicating that with the patient, understanding how the triage. Patients are happy to get to the person who's going to be able to help them solve their problem that day or the next day. Nobody wants to wait a week. Then we talked about how to optimize team function, and I've got to speed up, sorry. Triaging is very important, clarifying roles and communication within the team and communication back to the patient. Thanks.
Okay, thank you. Dr. Condé, votre groupe a discuté de la même question. Pouvez-vous nous résumer ce qui a été dit?
Merci. Le rapport va être en français, so if you could please put your headset so you can have the simultaneous translation. Alors, nous avions une table francophone ici. Donc, la première question était les membres de l'équipe que vous trouvez les plus utiles. Alors, c'était intéressant comme discussion. Donc, c'était pas tellement, on n'a pas tellement parlé des membres de l'équipe que plutôt des qualités de ces membres-là. Donc, ça prend des membres qui sont imputables, des membres qui respectent leur champ de compétences, des personnes avec un bon jugement, des personnes bien formées, expérimentées, de façon à éviter ce qu'on a décrit tantôt comme étant le dédoublement du travail, donc pour éviter que le médecin soit obligé d'aller revoir le patient. Et en même temps, on a parlé aussi d'éduquer les patients pour expliquer aux patients que s'il voit un professionnel de l'équipe, il n'a pas obligatoirement besoin de voir son médecin. Donc, ça, c'est ressorti. L'importance de la communication dans l'équipe aussi, une autre qualité importante. Pour éviter le travail en silo, il faut s'assurer d'avoir une bonne communication. Si la communication est mauvaise, chaque membre de l'équipe va travailler en silo et on n'aura rien gagné. Au niveau de ce qu'on aimerait avoir dans l'équipe, On a beaucoup parlé de psychothérapie, on connaît les difficultés d'accès aux services de santé mentale au Canada, donc beaucoup pensent que l'accès à des psychothérapeutes dans les équipes de soins et aux travailleurs sociaux qui peuvent nous aider aussi. Et on a élargi même le spectre. On a dit qu'on pourrait avoir des organismes communautaires qui se greffent au travail d'équipe. Certains patients pourraient être référés ou aidés par des organismes communautaires parce qu'on sait qu'il y a une pénurie de ressources, pénurie de psychothérapeutes, pénurie d'infirmières, pénurie de travailleurs sociaux. Et pourquoi pas des bénévoles? Pourquoi pas demander à des bénévoles de se joindre à nos équipes de soins? Donc, c'est une piste à explorer. Et dernier point, au niveau du support administratif, on a parlé d'avoir peut-être plus de personnel, d'adjoints administratifs dans les équipes de soins pour libérer les médecins du médico-administratif, de la paperasse. On sait que les médecins de famille passent en moyenne 10 heures par semaine à faire de l'administration. Donc, si on avait plus de support administratif, certainement que ce serait des heures qui pourraient être passées à voir des patients. Alors, ça résume à peu près les discussions à notre table.
OK, merci bien. Dr. Ross.
Been told to stand on the X. Just waiting to see if anything's going to fall on me. So ours was on the sacrifices and trade-offs in team-based care, and from a clinician and from a patient point of view. Certainly from a government point of view, we spoke a little bit about the need to look at our investments differently, and to, rather than focus on actual services that were provided, to focus on processes and outcomes to see if they were actually beneficial to patients and communities. From a clinician point of view, we spoke a little bit about loss of autonomy as a fear of moving into team-based care. I usually talk about that as physicians hanging on to the power in the patient-physician relationship, but that was on the list. And then we spoke a great deal from the patient perspective. Benefits were highlighted as continuity was better controlled if we were in a team setting, but the trade-off was that you may see a different doctor this year versus next year versus the next year, and yet the continuity of your medical home stayed in place, and patients felt better if they were matched with someone. Another point was on the succession of changeover of the caregiver. So if a physician was leaving or a nurse practitioner was leaving, that someone else was there to pick up your care. Definitely a sacrifice and a pitfall that we see is on the HHR shortages, which have been around since the 1980s, and how we were going to manage that. So I think I captured most of everything at our table. Thank you.
Thank you. And finally, Dr. McCracken.
Yeah, hi everybody. Our table talked about how teams would interact with the healthcare system, the network outside of the clinics. And I took the liberty, because I was in charge at my table, of telling a story, and I will share that with you now. So on a Friday afternoon, a patient who I knew well, elderly, frail, and very poor, came in, saw me, we chatted. Most of our visits are really just her telling me about her cat and me trying to get her to take her medications. And as she was leaving, she mentioned that she had a sore leg. She'd had surgery 4 weeks prior. I looked down at the leg. I realized that she probably had a DVT, which is a serious condition that can turn into a blood clot that travels to your brain or your lungs. And she needed some treatment. And I work in a team-ish practice, not a team-based practice. My waiting room was overflowing. I had 2 other emergencies, including somebody who was newly homeless and somebody who had HIV, had been off their medications, and probably had COVID and was in the office and was struggling to keep his mask on. So I was like, oh my God, what am I going to do? And I asked one of our new front desk people, I said, I know you don't know how to do this, but would you please call around to all the radiology offices at all of the hospitals and use these words, DVT, post-surgical, 4 weeks, frail elder, Wells score 5. And she's like, okay, sure, I'll do it. She was really excited. Miraculously, she found somebody who would do an ultrasound in 30 minutes. The bus from our clinic takes 45 minutes, and that was the only way our patient had to move around. But we scrounged up some petty cash from our front desk, and we sent her in a cab. So bad news was she had a massive DVT, and the good news is that there was an automatic pathway at the hospital that I'd never heard of for treating thrombosis for people who were found in the radiology suite. So everything worked for this person. It was what team-based care could be. And the bar's pretty low for how team-based care can work. We just need a neighborhood where people can talk to each other and where we can get the services that our patient needs, and where we don't need petty cash to send somebody in a cab. So that was what our conversation centered around. We also had some very important conversations about that the funding for teams really we can't expect it to come via physician remuneration. We can't expect a physician to be making a decision between getting new windows for their house versus hiring a team. That's not reasonable. We need to have funding that goes straight towards the teams. And then the other thing that we need to talk about, and I think some of the other tables touched on this as well, is that patients need to understand that team-based care is as good or better than them seeing their doctor, and that is an educational hurdle. Otherwise, people are going to start to feel that team-based care is not meeting their needs. So thank you very much for that opportunity.
Thank you, Dr. McCracken. Thank you. We're rapidly running out of time. Final thoughts to the two of you and reflections on what you've heard. Teri, maybe we can begin with you.
Yeah, I mean, we're always excited to be having conversations about teams and team-based care. Like I said, we're really excited about the momentum. I think one of the things that we're learning through a bunch of the different work that we're doing is really that we need both a shift in mindset towards the recognition that we need to work together and the system change that enables the conditions where it is easier to work together, whether we're talking about the micro level of the system or at the macro level of the system. I think a lot of the sort of historical approach or the assumption that a lot of the challenges in healthcare are sort of technical problems or we can sort of create rules to get our way out of it hasn't been effective. And so I think we do need to be challenging the status quo, thinking about things a little bit differently and recognizing that a lot of these problems, we need to focus on the people, we need to support the people. That means supporting primary care doctors, it means supporting the rest of the team that can actually meet the needs of patients and supporting patients and families in an effective way.
Tara.
I wanted to build on a reflection around a tension that Kathleen mentioned and an opportunity, I think, that Rita mentioned. So one of the tensions Kathleen mentioned, I think, is this tension between people's desire for a relationship with one clinician, something that we know patients want. We saw it really clearly in our survey results. And we also know there's a ton of evidence to support relational continuity and that leads to better outcomes, lower costs. So how can you have the benefits of that while still working in a team? So the patients do still need some connection with the most responsible clinician, and they need to know who the rest of the other team members are so that there is that relationship and some informational continuity, not just relational continuity. So there's a tension there. The opportunity, I think, Rita, like what a great case you described. A hairy life in an afternoon in a family doctor's office. Friday afternoon, always the worst. it actually made me reflect on my own practice setting, which I feel lucky to be in. So we look after 50,000 patients, and we have 5 clinics, and we're actually integrated with our hospital. And so that takes team to another level. So it's not just the micro team, but a neighborhood. And so we have mechanisms to easily get same-day ultrasounds with our local hospital, and I can easily call or email the specialists there because we're all part of the same kind of ecosystem. So what are the opportunities if we start to think beyond one single primary care clinic? But then last, I just wanted to end on a note of hope, because I think some of what I described in my presentation was a bit, it was a bit of a downer, but I do think like going to each of these priority panels and hearing what it is that people have to say really provided me with a lot of hope, because these are people, strangers, different backgrounds, and in a polarized world, increasingly polarized world, there was a lot that they could agree on. And so let's focus on that agreement, the things that people know that they want and can agree on when we think about how it is that we want to shape our future.
One final point, and it came from the table, from Dr. Kennedy's table and also Dr. Conde's table, that for team-based care to work, communication is critical.
Absolutely. Yeah, and I think that goes back to some of the fundamentals you talked about, Teri.
Okay. Well, Teri and Tara, thank you so much for your contributions this afternoon. Really appreciate it. Thank you.